So, Mia, thank you so much for being on the show.
Yes, my pleasure. Thanks
I
for
am
asking.
looking forward to this topic. I wondered, though, if we could just start with what got you into sexual medicine in the first place. Like, why is this what you do and are passionate about?
Yeah, good question. So when people ask me why I got into women's health or sexual medicine, I think the better question is more why I got into healthcare. I've always been really passionate about sexual and reproductive health, and reproductive justice. And so I've kind of looked at different ways to be involved in those fields and to make money and have a career while doing it. And so initially I actually wanted to go into sex education. And I thought that that would just be like my dream would be to teach like advanced sex education at like a community college level, go into the nuances of like masculinity and consent
Right, right.
and it's still kind of my dream, but the great news is that with my current training, I could go out and do that. And so when actually one of my best friend's moms, who's known me since I was born, when I realized how much money sex educators make with a master's degree, I thought, okay, that's not going to work for me.
Right.
And I kind of had a crisis of like, well, now what direction should I go in? This was shortly after undergrad. And she suggested to me like, oh, well, you should think about being a nurse practitioner. And I was like, no, I really avoided all the hard sciences in undergrad. And she was like, no, I don't think the post-bac is that long. You should look into it. And I realized that by becoming a nurse practitioner, not only could I do all of the education and all of the activism and advocacy that I wanted to do. But also being the provider to the patients is incredibly meaningful. And that's a whole other area of activism.
Yeah,
So
yeah.
when I ended up my first nurse practitioner job, I ended up at Planned Parenthood. It was like if you had seen 6-year-old Mia, you would not have been surprised that I ended up there and now I'm in sexual medicine. It's like a perfect fit for how I've kind of always been.
Yeah, yeah.
And it's so meaningful to do this work that in a lot of ways is really stigmatized, that people have a lot of emotions about. Sometimes it's just hard to find knowledgeable providers in some of these fields.
Oh, yeah.
So that is how I ended up here.
Yeah. That makes sense. And you're doing such powerful work. I mean, not just the medical care, which is so important, but the education that goes along with that, that so many
Mm-hmm.
people, I am sure that in your practice, you see tons of people that don't have, some level of understanding about even their anatomy or sexual functioning, right? Like it's
Absolutely.
such an
Yeah.
opportunity. Yeah.
Mm-hmm.
All right. So the topic today is hormonal birth control. And I thought maybe we could start with what what forms of birth control are hormonal and what kind of hormones are we talking about?
Yeah, so there are a couple of different classes of types of birth control. So we've got non-hormonal options, which I'll just touch on briefly. Those will be things like the Paragard or copper IUD. And by the way, I don't know where your audience is based. This is what's available in the United States. There
Okay.
are different options in other countries. But so there's the copper IUD, which is highly effective both as emergency contraception and as ongoing birth control. And then there is a gel, a contraceptive gel that is not a spermicide that a person would insert into their vagina with each act of sex. There's also a diaphragm that requires the use of spermicides, which is a specific type of chemical. And then there's also spermicides on their own. And then there are things like fertility tracking. And those are kind of the main non-hormonal options. And I'm happy to talk more about the pros and cons and
And
how.
I suppose condoms fall in that
Oh my
too
gosh.
with, yeah.
Yes, thank
Okay.
you.
I
And
was just thinking, what other
condoms.
ones? Yeah. Okay.
Yeah, so there's internal and external condoms. When we think of condoms, we usually think of the male condom or the external condom. Those can be made out of latex. They also have a latex-free option for people who are allergic. And then they also come in an animal skin version. I do not recommend that. Those are thinner, and the
Mm.
idea is that they're for supposedly better sensation, but the animal skin does not prevent against STIs because STIs
Ah,
are actually smaller. They're able to get through those cells. And nowadays with condom technology, you can get really thin condoms, so that should not be an issue.
yeah.
And then there is the internal condom, which the person who's being penetrated can put in themselves. So either inside the vagina, inside the anus. That one is non-latex. And then there's also dental dams, which are just barriers. They either come like as a square, like actual dentists used to use, or you can get non-microwavable plastic wrap or take a condom and just cut it down, one way and open it up. And that's just a physical barrier that you can use when performing cunnilingus or analingus. So oral
Yeah.
sex on a vagina and vulva or on an anus.
Right. Okay. So those are
Yes,
the
and then
non-hormonal.
and then there's also, I just want to mention, there's fertility tracking and there's withdrawal, and those
All
are
right.
valid methods. Now, all of these options, with the exception of the Paragard, are not going to be as effective at preventing pregnancy.
Okay.
Which is not to say that they don't work. They do. It's just going to be, when we're talking of how important is efficacy for you. For some people, it's not their biggest priority. They don't need the most effective method. They have other priorities, and so they may choose those methods.
Okay.
So then we get to hormones. And so there are two main hormones that are used in birth control. There's estrogen and progesterone. So there are pills, patches, and rings. When we combine estrogen and progesterone together, we call these combined hormonal contraceptives. And so those are the three classes that exist: pills, patches, and rings. Almost every pill is made out, and the patches and the rings are made out of an estrogen called ethinyl estradiol. And so when we talk about side effects or benefits of the estrogen, then that's the specific estrogen. I can get into, there technically are two other estrogens that are with pills, but we're really getting nitty gritty here, which for sexual medicine actually can be important.
Right, right.
And then there's progesterone, and there's a lot of different types of progesterone, different generations that have general characteristics that you can kind of assume. And so the reason why, well, before I get into side effects, progesterone on its own is used in birth control. And so we see that there are some pills that are progesterone only. There's the Depo-Provera shot. And then there are the arm implant, and there are progesterone only IUDs. With estrogen, all estrogen methods for birth control are combined with progesterone.
Okay. So you can get progesterone on its own, or estrogen and progesterone together.
Correct.
Okay.
Mm-hmm. Yeah. And when I'm asking patients, say a patient comes in for birth control and a lot of times they already have an idea of what they want, but if they have no ideas, then I'll ask them a lot of different questions, like, is it like, how effective do you want this method to be? Are you good at doing something every day? Not all of us are going to be good at taking pills every day. And the combined pills, as well as one of the progesterone only pills called Slind or drospirenone, they do have a 24-hour window. So they are very forgiving. You can take it anytime within 24 hours before you're late, but not everyone's going to be good at that.
Yeah.
And guess what? If you don't use it as indicated, then it's not as effective.
Right. Right.
So, and that's fine. There's no judgment. That's not the best method for everybody.
Right.
So there are patches that you would change weekly. There are vaginal rings that you would change every 3 weeks, a month, or a year. And then there's a shot that you get every 3 months. And then there are other what we call long-acting methods. And those you would leave in place for anywhere between 3 and 12 years.
Okay. So I'm particularly interested in exploring some of the maybe unexpected side effects of the hormonal birth control on sex. Because I guess there's the side effects that maybe are other things, but I guess you should touch on that too, if it affects people in other ways. But I've heard, some about pain, or is there anything about libido? Like, I don't know that people are going into these choices aware that this might cause some trouble.
Mm-hmm. Yeah, absolutely. And you may want to end up editing this because I can talk a lot about it. So we'll see.
We'll see
if we end up cutting it down. But so when we talk about side effects, we're usually talking, the side effects are specific to either the estrogen, the progesterone, or the type of progesterone. And then there are also what we call androgenic side effects, which means that some progesterones or anti-androgenic. And that can be basically how it impacts testosterone receptors.
Okay.
So the classic estrogen symptoms, or side effects rather, and these are, a person may experience this when they're starting a method, would be headaches, nausea, and breast tenderness. Typically they're mild, they go away on their own. Obviously if someone's really suffering, then we're not going to, I would not make a patient stick it out for the full 3 months if they don't tolerate it. But typically, if you do stick it out for 2 or 3 months, then they'll go away. Progesterone side effects could include fatigue, bloating, constipation. And then sometimes we do see a bit more mood, like certain progesterones may impact people's mental health and maybe cause more depressive symptoms. It's not very common, but if someone is noticing that, or if they have that concern coming in, then it would be a good idea. We can steer to either different types of progesterone or different doses. And then estrogen and progesterone, when you combine them, or really just the estrogen, which is always combined with the progesterone, has an impact on your body's free testosterone. So there's a lot of benefits, but the reason that these benefits occur are also the reason that these sexual dysfunctions can occur. So when we use methods that is called menstrual suppression or ovarian suppression, so you take medication, and I have patients who come in and say, I want a low dose. I don't want to be on a high dose of hormones. And so what I try to explain is that when we are on a type of medication that suppresses your ovaries, it basically lets your ovaries go on vacation. They're not retired. This is not menopause, but it lets them go on vacation very safely, because there's a negative feedback loop. So your brain is sending a signal, hey, we've got plenty of hormone on board. You do not need to work. And so so often when patients go on low dose hormones that are suppressing their ovaries, their hormone levels are lower than they would naturally be. And so, some people, you just need a certain amount of estrogen for your genital tissue to be happy. And we notice this postpartum, when people are breastfeeding, or in menopause. Those are hypoestrogenic states where your estrogen is low. And so your genitals, which have estrogen receptors, can get kind of angry. They can be dry, burning, itching. You can get pain with sex, or even unprovoked, or certain things like underwear, or touching, or things can provoke it. So when we suppress ovaries not only produce estrogen and progesterone, they also produce testosterone. Testosterone is really important in cisgender women, just like estrogen, surprise, surprise, is actually really important in cisgender men.
Yeah.
And cisgender women actually have higher levels of testosterone in our bodies than we do estrogen, but we don't realize that because the units are different. So
wait, let me just ask you a question. Mm-hmm. So the birth control is giving you estrogen and progesterone, but we're suppressing the testosterone, or suppressing the production of all three. What in the world's happening with the testosterone for people?
Correct. Yeah. Great question. So, when we suppress the ovaries, your level of total testosterone is going to be lower, right? Because your body's not making it. It's not going to be zero. You also have testosterone made from your adrenal gland, but it's going to be lower. And then additionally, when you take this ethinyl estradiol, which is the type of estrogen that we use, it goes through your liver, and it causes your liver to produce more sex hormone binding globulin. This is a protein that binds to testosterone, and hormones in our body, in order for us to utilize them, for them to be active, they need to be free or unbound.
Yeah.
So the total amount of testosterone that you have is just one part of the picture, because some people are able to utilize a lot of that testosterone, and then others have more SHBG, sex hormone binding globulin, that if you think of it like a group of people and you're single and you want to date, but a bunch of these people are in relationships.
They're all coupled up.
Yeah, exactly. So we, especially in sexual medicine, want to calculate someone's free testosterone, which is a side note. The calculation varies. Different labs will run the test differently. So it's not recommended to order it as a lab, but we can talk more about that later.
Okay.
But so we calculate someone's free testosterone. It's one of the things that we look at. So when we're suppressing the ovaries with birth control, we're usually using a method that is going to, by suppressing the ovaries, less testosterone total. And then of that total, now a bunch of it is bound to sex hormone binding globulin. So both are going to combine to lower people's free testosterone. What do we need testosterone for?
Yeah. So what's the impact of that, right? How does that show up?
Yeah. So testosterone has a lot of benefits. We can think of why like cisgender men choose testosterone for bodybuilding or for things like that. But we have testosterone receptors all over our body. And one, we have them in our brain, and testosterone plays a big role in libido and sex drive and orgasm. And then we also have testosterone or androgen receptors in our genitals. So let's do a little anatomy. I do not have I don't have any diagrams with me,
Well,
but
this is also audio largely, so you're
okay,
going to have to
perfect.
get descriptive here.
Perfect. Okay. So I think most people are familiar with the terms vulva and vagina, right? So the vulva is the exterior, it's the labia majora, the labia minora, we have the clitoris. And then interior, that birth canal, the canal that fingers or tampons or sex toys or penises or babies would go into, that's the vagina. But in between the vagina and the vulva, there is a lobby, an entrance called a vestibule. And this is an organ that I did not learn about in my women's health nurse practitioner program.
Yeah, yeah.
And I don't know that they are currently teaching it in most medical schools, or that people learn about it in OBGYN residencies or
Right.
urology
Or my
residencies.
sex therapy training.
Wow.
Yeah,
Yeah.
yeah, at least not that I remember.
I
I,
was going
I
to say, I
shouldn't
wonder
swear on that,
how
but
long ago did you do your sex therapy training?
2011.
Okay, I wonder if it's been updated. I don't know.
I don't know
But,
either. Yeah.
I only learned about it by taking trainings with ISWISH, the International Society for the Study of Women's Sexual Health. And that's when I learned about the vestibule, which is this organ that differs from the vagina and the vulva embryologically. And so what that means is the vestibule is a very small area. It's from right below the border, the anterior, meaning the top border is the clitoris. And then it goes down to like the perineum or the taint. And then on either side, it goes up to the labia minora. And so,
Okay.
and then on the interior, it meets the vagina. So really small area, but very important area because it's very hormone sensitive, not only to estrogen, but also to testosterone.
Mm.
And so when we put people on low dose pills, which a lot of my patients love, and they come in requesting, and I love these pills, but for some people, that's not enough estrogen for them. And for some people, they are going to be impacted by that lack of testosterone. And so what we end up seeing is that the vestibule, which is, you can't get into the vagina without passing through the lobby, that this area can become, it can feel dry, irritated. You can experience pain with sex.
Yeah.
But also just like itching, burning, some other symptoms as well.
And how common is this? Because I have definitely heard this, and I don't think people know to expect. I think they're surprised fundamentally. I don't think they know to expect this or to look for this, or they don't understand this is what it is. How common is it that somebody's going to end up with like pain from the birth control?
Great question. I think that there have been different studies that have come to different conclusions. What I generally tell my patients, because I have patients come in and they're worried about a lot of different symptoms, most commonly things like weight gain or, other side effects like mental health side effects, affecting their libido. And I tell them most people tolerate most birth controls really well.
Okay.
So side effects overall are pretty rare. And this sexual pain, I don't know how well it's been studied, but there have been a number of studies that have come to different conclusions. But you're right, this is not something that I was aware of. And I got excellent training on the nuances of birth control and the different types of progesterone and different benefits and side effects. And from Planned Parenthood, where I worked for 3 years, I really considered and still consider myself a birth control expert. And I really had not heard that a small but significant percentage of people are going to have pain or maybe symptoms that they don't even interpret as pain, but as like itching or burning, and that it might be coming from their birth control.
Yeah. Yeah. And for those where it does happen, I mean, it's a big deal, right? Like this is,
it can
this
be.
is going to have,
and then again, and some people are going to feel that decreased libido. Now, a lot of people feel relief because they know they have not 100% effective, nothing is, but that they have very effective pregnancy prevention. And so they're able to engage in sex,
right.
With and feel much better about it. But yeah, some people it is going to affect their libido. Because again, testosterone is one component of libido, and most birth controls are going to reduce that.
Right.
Now,
So,
go ahead.
well, no, go ahead and finish before I
So I
ask
was
my
going to say,
next question.
so like, why do we use birth control? What are the benefits? Why would, if this is a risk, why would you want to suppress the ovaries? There are so many benefits to suppressing the ovaries. I use birth control for my patients all the time, not for pregnancy prevention. Although if they're trying to get pregnant, I'm not going to put them on birth control because that will not help.
Right.
But, maybe they're not sexually active or they're not sexually active with people who make sperm. But for things like skipping your period altogether, I personally have not had my period in years, and it is very healthy to use birth control to skip it. And who wants to bleed? Like, that's just an inconvenience that I don't need.
Yeah.
But also people with irregular bleeding or with heavy bleeding. Some people have significant anemia because they bleed so much with their menses. We can easily skip that with birth control. Some people have very painful periods, or they'll have like PMS or PMDD symptoms where it's affecting other symptoms or their mental health. Again, we can suppress your ovaries. We can skip that. Then there's also different conditions like I mentioned painful periods, which often is endometriosis. There's fibroids, which are non-cancerous growths in the uterus of the uterine muscle that can cause a lot of different symptoms, including abnormal bleeding, pain. If they grow really large, you just have the symptom of like a grapefruit sitting in your pelvis.
Yeah.
And then there are ovarian cysts, which as part of the normal menstrual cycle, everyone forms these cysts that then resolve. But for some people, the formation of the cysts can be painful to begin with. Their ovulation can be painful. It's rare, but I've had patients who report that, and it's known. Or more of an issue is if these cysts either rupture, they can leak blood, or sometimes it's not such a leak. Blood gets into the abdomen. It's very irritating. And so a ruptured or something, it's called hemorrhagic, which sounds very dramatic, but a ruptured ovarian cyst can be very painful. And we basically you just kind of have to wait 8 weeks for it to self-resolve unless it's so bad that surgery is indicated.
Wow.
And so some people do require emergency surgery because the bleeding is not stopping, or they'll develop cysts that just continue to grow and do not resolve, that again, they end up needing surgery for. So we can't treat it very easily, but we can prevent it really easily with birth control. And then I didn't even talk about acne and hair growth. People who have PCOS, polycystic ovarian syndrome, which is this hormone imbalance, and it has certain implications for their health. They're more likely to be dealing with fertility issues. There's cardiovascular implications long term. They have to make sure that they're not getting a buildup of the lining of their uterus because that would put them at risk for endometrial cancer. And often they'll have like more male pattern hair growth and acne. And so guess how we fix that? We suppress your ovaries. We keep that testosterone low because these people have more total or free testosterone available to them. And yeah, we just manage it really easily with birth control.
Yeah. I mean, this is a lovely detailed conversation about the benefits of this besides just pregnancy prevention.
Yeah,
in our political climate and everything else, this is like really important.
Not to say that pregnancy prevention is not a hugely important
right. That's
issue,
a huge,
especially in the United States in today's day and age. And again, just to reiterate, even with some of these methods are very effective, no method is 100% effective. And I have seen every method fail, including tubal ligation. I've had 2 patients come pregnant after a tubal ligation. I've seen every IUD fail. I've seen every method. And so it's about reducing risk, but there is no method that is going to be 100%.
Right. So if somebody does end up with pain, itching, burning, whatever these tissue symptoms from the birth control, if they switch methods, if they stop, does this resolve, or is this something
Yeah, really important question.
Yeah, because I think I've had clients say they got off birth control, but the pain persists. So I don't know. I mean, that's just anecdotal, but
yeah. No. So I think the most important thing is, we need to determine what's causing your symptoms. So first, there needs to be a workup of, is this vaginitis, which is kind of an umbrella term. It could be things like bacterial vaginosis or yeast infections, which I think probably most people have heard of either of those 2 terms. Those are really common. Those are, I think like 40-ish. I'm not exactly sure of the percentage, but it's close to half of adult women are dealing with bacterial vaginosis at some point. And, some days in my clinic, it feels like every patient, I'm just diagnosing it left and right. And I'm like, am I over diagnosing
You're
this?
right.
And I look up the statistics and I'm like, oh no, it's very common. Okay. So those are things that are much more common that you would want to rule out. You would also want to rule out skin infection. So someone does need to go and make sure that it's not any of these other causes. And if you're ruling out all the more common causes and then, sometimes timing can be helpful if it comes after someone started a birth control, but a lot of times people will be on these methods for a long time before any issues arise. So if we suspect or determine, or you think that it might be your birth control and you just want to try switching it, you can absolutely come off of your birth control. And we can switch to a birth control method that is less likely to cause sexual dysfunction if you want pregnancy prevention. So the best methods from a sexual medicine perspective would be things that are not going to suppress your ovaries. And keep that testosterone low. So that are going to be non-hormonal methods. And then it's also going to be of the hormones, the hormonal IUDs, which go by the brand name Mirena or Liletta. There are also 2 lower doses called Skyla and Kylena. Those will give a lot of the benefits of birth control. 98%, 99% pregnancy prevention. But then also they will thin the lining of the uterus so that most people will either have very light periods or their periods will totally go away, which also helps to prevent against endometrial cancer. So if someone has PCOS, for example, and is having irregular menses and we want to make sure that lining doesn't build up, this is a great option. It is indicated first line for fibroids, for endometriosis, for heavy periods. It does not prevent ovarian cysts. So if that is a person's problem, then, this method might not be the one for them. And then there's also the arm implant, if you can see.
I can see her arm. Yes,
yes,
I'm looking at her arm.
Which goes kind of near your bicep and has a lot of similar benefits to the Mirena or Liletta. It makes your periods go away. It also suppresses your ovaries, but it doesn't seem to affect testosterone to the same degree. Those are kind of the preferred options for the best bet for least influence with your testosterone.
Okay.
So some people may stop whatever the problem is, whether that's postpartum, breastfeeding, or their birth control, and then their body may recover, and they may not need to add any additional intervention. Just give it some time. But a lot of people, they're either not going to recover sufficiently or they just need help to get their hormones back to where they want to replenish that tissue. And so typically this is going to be with local testosterone, estrogen, DHEA, which is a hormone that's a precursor to both, meaning your body converts DHEA into testosterone and estrogen. And so these would be like suppositories that you put up your vagina, or creams that you rub into the vestibule, which again is that lobby, that exterior part of the vagina. And you can also put it in the entrance to the vagina. And so that can help get those hormone levels in your genitals back. You also can try systemic testosterone or systemic estrogen, for example, like in menopause, which is when someone's ovaries have retired. They are not on vacation. They're not back from retirement, typically. And so estrogen also is going to help replenish those tissues. And so for some people, giving hormones systemically is going to kind of trickle out throughout the peripheral body and will get to their genitals. But often it's a good idea to do very, very low doses directly to the target tissue to ensure that tissue gets what it needs. And then you avoid systemic hormones if it's not indicated for other reasons.
Right. I mean, I don't know quite how to ask this. How likely is it that people are going to find providers who know all this and are willing to deal with it, to even take it seriously, and then to figure out what the cause is, and then to replenish these hormones? I mean, I'm just sort of thinking about my own historical medical experience. I'm thinking, I don't know that a doctor would have even taken the pain seriously, much less known what to do about it.
Right. So the good news is that your experiences occurred in the past.
Yes.
And I know I'm in a bubble, but it does feel like there's a lot of growing awareness, at least about menopause and perimenopause. And so if you start there and we're talking about hormone depletion and the effects that having low hormones can have, then it very easily translates to, okay, but what about people who are breastfeeding, right? Like, and then also, you can take that one step further to what about birth control, especially with these low dose birth controls being so common and really popular. And again, having a lot of health benefits, but then also potentially some downsides. So I don't know, probably, and again, I do not recall at my Planned Parenthood ever learning that birth control could cause pain with sex.
Mm-hmm.
And when I would have patients come in, I just don't remember being aware, and I kind of jumped in headfirst with sexual medicine training about a year ago.
Okay.
And I always kind of knew on the periphery that I was interested in it. And then I was able to attend this first conference that was, again, an ISWISH conference. It was drivable distance. And I was like, great, I'm going to go. And then I just couldn't sleep. I was so excited and signed up for a bunch more courses and trainings and read a lot and listened to a bunch of podcasts and it naturally, the overlap between sexual medicine and menopause and perimenopause, but again, it's hormones in general,
Right.
led me to get certified as with the Menopause Society as a certified practitioner. And now in my current role in my sexual medicine practice, I deal with menopause all the time, or perimenopause, or birth control, as well as we also have a lot of men, and we deal with their testosterone, which decreases with age as well.
Right.
So I feel like there is growing awareness, especially of the need for vaginal estrogen during breastfeeding, and in peri or really with menopause. And part of that, actually, I was really heartened. So ACOG, which I want to say is the American College of Obstetricians and Gynecologists, they are a medical society that to be a board certified gynecologist or a board certified OBGYN, you are a fellow of ACOG. And so they have a lot of influence. And for people to maintain their board certification, they have to read specific articles that ACOG chooses to put out, and then I think answer some questions about it just to show basic proficiency. And so a physician coworker of mine showed me, because she knew I was interested in menopause, she showed me that ACOG, some of their articles were about different menopause treatments. And so this is one way that they can ensure that, this information is being disseminated.
Yeah.
Now, that talked about estrogen specifically. Talking
Yeah.
about testosterone with cisgender women is very, very niche. And again, it's not very likely that you're going to find providers comfortable with that if they have not been exposed to sexual medicine training.
Right. Right. Well, one more question before we talk about where people can find you. I know personally, I know that with menopause, lab work is a part of this process, figuring out the starting point, and monitoring where you are. Is that something that's appropriate when people are, going to use hormonal birth control? Do you start with labs? Do you follow up with labs? Or is that only something you're doing if there's a real problem?
Really good question. So I would actually say lab work is kind of controversial in where its purpose is. The practice that I'm at, which is with Dr. Irwin Goldstein and Sue Goldstein, who's an amazing researcher at San Diego Sexual Medicine, we do check labs quite closely. But actually, a lot of the medical societies say that labs are not usually indicated and that you can treat based on symptoms. We also will treat things or we will treat patients with contraindications that other people may not feel comfortable with. So that's another reason why we like to have those labs. And then again, testosterone, there's a lot that we as medicine and as sexual medicine, which is this subspecialty that I think has existed basically since Viagra, which was like the late 1990s.
Well, since Dr. Goldstein sort of founded this whole
Correct,
field,
yeah.
right? Yeah.
Very fortunate to work with him and Sue, but
Yeah.
it's pretty amazing. But it's such a new field. We're learning so much, and there's so much that we have learned and that we've gotten really good at. There's still a lot of areas where I just think we don't know that much about yet, and that we don't have that great of treatment yet. But so as far as hormones, For birth control, Dr. Irwin Goldstein and then another doctor in sexual medicine who's named Andrew Goldstein, and he's actually an OBGYN, they wrote a paper together in which they tested different patients, some of whom had what's called hormonally mediated vestibulodynia. So we talked about the vestibule, which is that lobby or entrance to the vagina. When you have pain with a body part, that's the dynia. So this is
Right.
vestibulodynia, and there's different causes of vestibulodynia. And in this case, we're talking it's from the low hormones, so hormonally mediated vestibulodynia. And so they looked at patients who were on birth control and had been diagnosed with hormonally mediated vestibulodynia, and patients who did not have pain when they were on birth control. And they were able to find a anomaly in their blood that if we had the resources to test everyone's blood before they started a birth control, we could actually find out who is likely to have pain and who is not. Now,
Oh,
it would be
interesting.
prohibitively expensive. And also, I can just tell you, from working at a place like Planned Parenthood, and to be clear, I do not speak for Planned Parenthood, but I am a current and former employee. But so, we don't want any obstacles to patients starting a birth control.
Right, right.
Because that is more likely to result in pregnancy that can be devastating for people. So, in theoretically, yes, it is possible to do a blood test to find out if people would respond poorly, but it's not practical or available.
Right.
And then as far as perimenopause or menopause, again, this is going to vary according to different providers, but many providers manage these conditions without blood work. So
Yeah.
there is value in it, but it's often may or may not be needed. And it also kind of depends on what you're looking at, because if your general menopause management versus if you're sexual medicine, then do you have exactly the same goals and ranges that are acceptable?
Yeah. Gets nuanced for sure.
Yes.
Yeah. All right. So just say a word about where people can learn more, find you, reach out to the clinic, where, because you
Yeah.
guys are
So
such an amazing resource that I'm always happy to promote. So,
yeah, thank you. So I am with Dr. Irwin Goldstein at San Diego Sexual Medicine. We do see patients, and male and female, all ages, all different types of sexual problems. And sometimes it's not actually a sexual problem, but it's a problem in their genitals or in their pelvis or even in their bladder. And so that falls in the category of sexual medicine. But some of our screening questions, in depth about orgasm and arousal, can make people very uncomfortable if it's not what they're there for. But
right.
so we are based in San Diego. Dr. Goldstein does do 10-minute courtesy calls, which are free calls where you can, talk to him about your problem, and he can see if he thinks that, we could be of benefit for you, in which case he would recommend that you come in and see us as a new patient.
Yeah.
There are also a lot of other great providers out there for birth control and hormones and pelvic pain. For sexual medicine in particular, ISSWSH, the International Society for the Study of Women's Sexual Health, is a great resource, and you can look up providers that are somewhat affiliated with them. And then, I just in general think Planned Parenthood is an amazing resource for birth control in particular. And many of my coworkers at Planned Parenthood as individuals are very interested in sexual medicine. But everyone's an individual, right?
Right.
And it's the same
Right.
with gynecologists, right? If you go to the gynecologist, there's no guarantee that they're going to be educated in this area. So,
Right.
Sometimes I have recommendations. I'm like, oh, you're in San Diego, go to this provider.
Yeah.
I would see her. But yeah.
Great. Well, thank you so much.